Hello, everybody. My name is Tony Whitehouse, and I'm a consultant in intensive care at the Queen Elizabeth Hospital in Birmingham. It's my enormous pleasure on World Sepsis Day, a day that is dedicated to improving education, recognition, and also understand research around sepsis. I learned the other day that somebody dies every 2.8 seconds worldwide from sepsis. I don't know how those figures have come around, but that sounds quite a lot. And so for today, we're running a seminar that is run by three of my colleagues. We'll first hear from Avinash Jha. He works in Preston Hospital. We're very grateful to him for standing in at the last minute for Matt Morgan, who is unfortunately not able to attend today. Avinash trained in India, came over to Preston quite a few years ago, where he works as a FUSIC heart mentor as well as a consultant in the ICU, and has a particular interest as well in the ultrasound of the brain. I'm also joined by Melissa Burnside. Melissa is the lead deterioration and sepsis lead specialist nurse at Newcastle upon Tyne NHS Trust. And she's challenged by working in more than one site throughout Tyneside, and there has to therefore make sure the delivery of recognition and sepsis care to both very young paediatric patients as well as very old up to geriatrics. And last but not least, we've also got Nicola Kelly, who's a consultant in paediatric ICU at the Birmingham Women's Hospital. And so she's entirely paediatrics. And the way we'll run today is that Avinash will talk about adult sepsis and give a case scenario, during which time we'll have a discussion. It'll be fairly free form. And after about another 20-25 minutes, we'll move over to Nicki and have a paediatric perspective to begin to try and compare and contrast the two. So enough from me. Thank you ever so much to everybody for joining us today. And Avinash, over to you.
Yeah, thanks, Tony. Good afternoon, everyone. It's a pleasure for me to come up with this presentation today. So, like Tony mentioned, I think we're going to go via a case discussion, and we will take in comments and inputs as we go through the case. So, moving ahead, we've got a patient who's come on to the medical assessment unit. He's a 68-year-old male, and his complaints were mainly fever and rigors for the last 3 days. And he also does mention about some burn maturation. On examination, his heart rate was 140, blood pressure of 88/40, and respiratory rate of around 25 breaths a minute. His temperature is 38.2 degrees Celsius. Now, going a little bit into his background, he does have history of ischemic heart disease, and going by the online records available, it was found that back in 2020, his left ventricle ejection fraction was around 35%. And when we ask him as to how he is as a baseline person, he does mention he's otherwise well. But once we dig in a little bit more in detail, he does agree that he gets short of breath on using stairs and hasn't used stairs for around 4 years now, and also needs help with bathing. So this is the main issue at hand. Now, given how things are, we just have to discuss and go in depth as to how we rationalize our approach. So firstly, since this is on a ward, what do we do? What do we do next? Do we go ahead with resuscitating him? Do we call the ICU straight away? Or even if he's accepted by ICU, what kind of a level of care will we provide in this case? So those are things we'll be discussing upon. So any inputs as to what we should be going ahead with first, and what would be the basis for it?
Yeah, thanks, Avinash. So I suppose this is a continued problem, isn't it, in intensive care, is that I'd like to think that we could have a situation. So I suppose that we should be talking always from the perspective that there's always enough ICU beds, that the provision of ICU beds should not be based around how many beds you've got, but whether the patient needs it. And more to the point, whether the patient would benefit from it. So I wonder if anybody on the panel would have any views on that. And equally, if anybody attending the webinar has any questions or any comments, if they could either put them in the Q&A, where they'll then we'll then amalgamate them and put them together, or perhaps in the chat, and we could begin to listen to people's views. But what are your thoughts? Melissa, have you got any thoughts about this?
Yeah, Tony, no, I think that's exactly right. I think obviously we're talking about sepsis today, but what we're picking up on is deterioration of patients. And I think when we see patients deteriorating, it's really getting to the base of what do we need to do, where do they need to go. Really, we sort of say Newcastle as well, same thing. If there isn't a bed, if the patient needs a bed, we need to make a bed. But it's exactly as you said, we need to make sure, is it appropriate for that patient to be escalated as well? And actually, are we doing the best thing for that patient in terms of their quality and what to achieve?
Yeah, and certainly one of the things that I think is often a challenge for adult intensivists is about this. And certainly in our practice at the QE, we will often admit patients, see how they respond. And then actually, once you've tried that, it's an easier conversation to have either with the patient or their relatives around limitation or withdrawal of care. That's perhaps different from some of the pediatric patients that you might get, Nicki. I don't know if you're going to touch upon this later, but do you have any comments about this at the moment?
Yeah, I can touch upon it later. But essentially, we'd always offer intensive care should, particularly should the family wish for their child to receive intensive care, even in the setting of, a patient with very severe chronic illness in the background, because we'd recognise sepsis as being a, potentially treatable, reversible condition, and that everyone should have the opportunity to receive appropriate care in that setting. But there are some sort of complexities, and I can touch on them if we have time.
Yeah, I mean, certainly, if we do have time, one of the things I'd be interested in is, I think from an adult perspective, we always worry that the impact of critical illness helps to, or contributes to the exacerbation of coexisting illnesses, perhaps worsens them, accelerates aging, and also the loss of muscle mass and the like means that patients don't get back to where they were beforehand. And so certainly a very debilitated patient perhaps then doesn't have the opportunity to recover quite as well. Does that sort of happen in the pediatric world? Do they shrug it off and then go back to their baseline state?
So generally speaking, kids are very robust, and it's not uncommon to have a child that has sepsis, goes into multi-organ failure, is on life support, recovers within a day or two, is extubated and eating a happy meal within, a few hours. That they don't sort of sit around children. But I think, that there can be sort of a cumulative impact on children that might have background issues and then have a number of critical illnesses. And yes, I can cover that a little later.
That's lovely, thank you. Avinash, back to you.
Yes, so now the first question, what do we do next on a ward level, this is. So of course, there would be some indicators to tell us that there's something going wrong. And in the past, we've used, say, in America, which was as per the sepsis guidelines, they did come up with Q-surface score. And then I think later on when we compared it, we did realize there were problems with the Q-surface score in itself. And that's when from news, we moved to something called as News 2 score. And I'm sure majority of us are aware of this. And it was just a little bit more in-depth scoring system, very similar to news on the same variables. But before we get into the detail of that, if you just look at the News 2 scores, it's very obvious that with a score of greater than 5 is where we should start thinking about sepsis. And anything less than 4, it would be a ward-based response. And as you see, it's obvious again that as the scores keep going up, the threshold for response is going to be higher. And that's why one of the names given to these scores is trigger, trace and trigger, wherein we trace the scores on a regular basis. And if there's a problem, we trigger them. So probably that's the first thing. We look at patients who are at high risk of having sepsis, irrespective of what the history is. We don't know what's going on in detail. And that's something in detail that's available on the sepsis website. And it's very useful. And they found it that compared to Q-surface score or any other scores, they were more sensitive in picking up patients who are unwell. Now, like I said, I'll just zoom in on the scorecard here. And it's very similar to the new score where we look at airway and breathing combined and look at the saturation and the respiratory rate. And you can see this, wherein we've got numbers to these individual components as 3, 2, or 1. And that's how we start scoring patients depending on their variables. And like I said, it's very similar to news, but a little bit more in depth. Once we get that score,
Avinash, just before we go too further, I'd just like to bring Melissa in there and just ask her about her experience and the sorts of things that are happening in Newcastle about that.
Yeah, so it's as actually it's like the news. We've just recently had a national mandate within adults to News 2, so that's been widely spread nationally. And what we found is with News 2 that it is a great predictor of potentially of mortality and picking up on them deteriorating patients and really focusing out, as we said with the Q-SOFA in Newcastle, we actually use the red flags. So from the Sepsis Trust, we would use the red flags rather than Q-SOFA, which is actually really built into the News 2. What we found is it picks patients up really well for that indication of early deterioration and trying to pick up on them early. But we do know that there's still sort of a lot of soft signs that aren't maybe in the News 2 that we want to look at. So looking at patients with maybe nursing concern or families got a concern around that. But it's really using this as a tool and a guide to then implement the management around sepsis or other forms of deterioration. But it is currently working well. But you've got to remember to use your clinical judgment within each individual parameter. So the scores are great. We know that if you have a News 2 of 5 or more, I think it's about 20% chance mortality. As you get up to 7, that's increased and doubled up to 40%. But it's remembering about what is the individual parameter that you're concerned about, because that's going to give you an indication around the diagnosis of what's actually going on with the patient. So it's taking it as a holistic approach with everything else that you're looking at.
And so I'd just like to take the opinions of the panel. How do you think this interfaces with just recognition of the deteriorating patient anyway? One of the things that I think we worry about in our hospital is that concentrating entirely on sepsis, whilst at some level is great, and great that the Sepsis Trust has come up with all of this, but at the same time, it does worry us that it then detracts from other deteriorations that can occur. The most obvious one in a surgical hospital is postoperative bleeding. Where does that interface sit, and what sort of problems do you think could have been arisen in your hospitals because of that? Avinash, have you found anything?
Yes, like I said, Tony, this is very specific for sepsis. So if we are suspecting sepsis, we tend to look at this. But yes, it can somehow digress people looking at patients as well. There have been patients who've come in with chest pain, with acute coronary syndromes, and unfortunately, because there's been so much focus just on sepsis compared to the rest of everything else, things do get missed out, and people don't tend to think, especially at a junior level when the experience is still less. Somehow the focus is more on just sepsis, whereas the other conditions, other medical conditions, they do take a beating to some extent.
And Nicki, I mean, I don't know about you, but it sometimes worries me that we do have, could it be sepsis written on the sides of ambulances, but there isn't, for example, could it be asthma, when there's anything up to 2,000 young people die every year from asthma attack because they don't get to hospital in time and they're having an asthma attack at home. I mean, where does this sit in terms of recognizing sickness generally rather than just sepsis?
I mean, I think in terms of from a community perspective, I think that, the Sepsis 6 for children does, flag up children that will have a broader range of diagnoses other than sepsis, so that's helpful. And I think from an inpatient perspective, we tend to go more on the PEWS, which is the Pediatric version of the news score, which again is looking at sort of whether the child's parameters deviate from the norm. And for children in particular, also encompasses concern of nursing staff or concern of parents, which is, in my mind, key. But, you know, certainly we don't always get it right. We don't always recognise deterioration early. And there are a number of things that we have in place. I can see in the chat that Janine had mentioned about outreach teams. I mean, we certainly have an outreach team from critical care in our hospital, and they provide a really good interface between the critical care and the ward level patients, and those that sort of fall into a bit of a grey area where there's concerns from staff. And I think that is an excellent tool as well.
Yeah, I know we're going to touch upon pews later, I think, in your talk. And certainly one of the things that really intrigues me is the relative concern or family concern aspects of this. I'm afraid it's not something I'd ever really thought about or come across in adults. Perhaps there are hospitals that are. Melissa, do you have an experience for adults family concern?
Yeah, so as we were saying, in Newcastle, we're a little bit different in the sense that we use the News 2 and that gives us a score. But then because we're fully electronic, we've been able to put our local adaptations on that. So if you have a patient that has a News score of 0 and you're quite happy, you might just want to continue 4-hourly obs and just monitor them. If you have a family concern that says this is just not like them, they're not that well, we don't have a specific family concern to add, but the nurses can add a concern onto that. So if they put a nursing concern on, it would not change the News 2 score because that's a national mandate, it's set, that's our guidance. But what it would do in our trust is it would increase the risk to a high risk patient, and that would initiate the action that really that is the same response as a News 2 of 7. So if that nurse and family have a concern, then it should be escalated in that manner. And as we said with the outreach comment, all our high risk patients would then have to be called outreach as another safety net to review as well.
Yeah, I mean, that's a really good point, and certainly something that I'm going to take away from this, because, you know, how many times have I had to sit in front of families in a relatives room when the families have been saying we're really angry because we've been saying to the ward for days that he's not right, and I do wonder how we can begin to fit this into our general attentions and warnings with families. I see from the chat that Felicity Kempson has written about antibiotics. I think it is really difficult, isn't it? I think there are moves to increase the time to antibiotic. The aim or the audit target of being less than an hour for inpatients is probably going to move in some hospitals. And I think that would be a really useful thing to do. Personally, I agree with them that antibiotic overuse is a somewhat of a concern. And I think some of it is about communications. And before talking too much, I think I'm going to hand back to Avinash, because it sounds like that's exactly what you're going to touch upon now.
Yes, I change slide, because antibiotics, yes. And again, there's a lot of question as to who's going to order saying we should be giving antibiotics. It should be a senior person who's experienced enough, which is, I think, what the sepsis guideline says as well. But however, the timing is very crucial. I think the incidence of death goes up with every hour delay. And it's nothing, you know, rocket science to guess that people do die because of sepsis, because again, at molecular level, the bacteria does multiply at a much exponentially higher rate with every hour that passes by. So every trust has their own policies on antibiotics, and this is actually based on the resistance patterns and what they've been seeing in that community. So we just have to trust them and go ahead with antibiotics. If there's a doubt, we go ahead. And I think, like Melissa did mention, that we have to have a holistic approach. There can be conditions like neutropenic sepsis, where these obvious signs like fever and a change in white cell counts may not be very evident. But clinically, if we do feel that there is a high risk that this patient might have infection, we don't have to wait for blood tests and cultures and other tests like CRPs or procalcitonin. I think in such cases, we have to be a little over-aggressive compared to the rest of them. And
yeah, I think you touched on something really important there, isn't it? It's probably about the specialists on the ward also being alert, isn't it? So as you say, that there are times when the hematology patient or the patient on steroids isn't responding in exactly the same way, just as I guess children don't respond in exactly the same way, and we're about to come on to that case. Avinash, I'm just very aware that time is slipping by. Have you got any other slides that we can move on to?
Yes, I've just got one more, which is here. And the reason why I've put this is we did, if we go back into the history of the patient, there was mention about his baseline functioning, which wasn't very great. And that's another area which is gray, where a lot of decision making can depend upon how the baseline function of the patient is. And if you look by this chart, which is again suggested by NICE to follow, his frailty score comes up to around 6. And why this would be important is, again, when somebody is going down to intensive care, like you've already mentioned, Tony, that would we, escalate the care to level 3? Would we, put him down to just vasopressors? Would he have dialysis, not have dialysis? So all these decisions will actually matter on his baseline function. And as popularly quoted, it would be his physiological age rather than the chronological age, which is a concept which I'm not too sure other medical specialties have an in-depth understanding about. And majority of the times we do get emotional saying, yes, we have to do everything for a patient, but there must be a fine balance where at one point we say, yes, we will do what's needed, what would benefit, rather than put the patient to more suffering and, take away their dignity.
Yeah, it's an interesting point, isn't it? Because we did reinforce this in my institution much more strongly during the recent first COVID wave, where we took into account the impact of being ventilated for what could be quite a long time. We took that impact into account on then increasing somebody's frailty. And certainly the data that we're beginning to gather and analyze, and also seeing from around the world, is that if you are very frail with COVID and then end up in ITU, actually just persisting doesn't seem to alter the outcome, and that actually these patients don't seem to make it through. Are people looking at the frailty score and applying it more rigorously perhaps than they used to pre-COVID, do you think, Avinash?
Yes, absolutely, Tony. I think one of the protocols we are following, very much similar to what NICE has laid out, we've been looking into clinical frailty scores to come down to a decision whether somebody should be for ward level care. Is there something medically incapacitating them to have a more worse outcome? And then we can probably screen patients who can come to ICU, benefit from at least a CPAP sometimes, and they have done well. A lot of patients have come in and we've said, we would be for level 2 as a CPAP, and they've gone out of our ICUs as well. But we've seen a few patients who were also 70, but a good baseline, surprisingly, maybe a frailty score of 3. But, again, it's difficult to put the numbers down. They've not been doing well as well. Perhaps it's the age-related physiological changes that come into picture. And if somebody also has substantial amount or substantial number of comorbidities, that just adds up to everything else.
Yeah, absolutely. And I've just seen that Nick McCartney's put in that the ICNARC 4.0 will begin to move into it. And I think for me, key to that will be about training and scoring this properly. Certainly during COVID, we had a couple of young people with COVID in their 20s, but actually because they'd come from the paediatric hospital with either a syndrome or severe illnesses associated with birth injury, that they were very dependent, but actually did very well. And it was very difficult to score them in terms of frailty, because although they perhaps used wheelchairs or Zimmers or didn't move or needed a lot of care in their daily living, when it came to it physiologically, they were very young, and I suppose scoring that properly is quite a challenge. Melissa, do you think clinical teams on the ward take frailty into account before they refer to ITU? And more to the point, how formal is that in your trust?
So I think it's the same. It's one thing that's been challenging for years when I've been on critical care outreach and on ITU previously looking at these patients. We did find the same as you, Tony, that when the first wave of COVID came, the exceptional response to actually reviewing these patients, getting frailty scores, would they be acceptable, putting sort of appropriate treatment escalation plans in was very much heightened and improved dramatically. And that really helped us decide who should go to ITU and not. We found it continued a little bit afterwards, but we have found it's tailed off again. So it really helped the outreach teams and critical care, but we're finding we're drifting a little bit back, that now they'll refer and wait for ITU or outreach to make the decision should they be escalated, rather than being possibly a little bit more proactive. But as you say, it's a really difficult decision to make. It's difficult to talk to family and relatives about it, the decisions of why we wouldn't take you, but it's that understanding that if we take you and you come out, you're probably not going to be back at your normal function. That is now, it's going to be a little bit worse. So it is really difficult. We're definitely trying to improve it, but there's, I think, still a long way to go to get them decisions made early, especially with the news too, like Avinash said, that when we get that score, really that should be a trigger for, yes, the patient's deteriorating, but to make them decisions of, well, what happens if they deteriorate further? What are we going to do? And that's the point we really need to start and have the discussions, because it will impact the care. And like Avinash says, it's looking at their dignity. We don't want to take people just to ITU for, just to cause harm or not improve the outcome. It's about keeping their dignity and improving that.
Yeah, I think that's a really good point that perhaps we can bring back later, is that the triggers, I think we often forget in ITU that I think clinical teams on the wards do have a filter. It's perhaps sometimes feels that there isn't, but I think they generally do think hard before giving us a call. But of course, the metrics by which those standards are judged often is around the actions against a very simple score and a very simple output. And so that can sometimes mask all the thought that does go behind. I'm aware that time's going on. Nicki, I didn't want you to feel excluded from the frailty score, but you're going to touch upon that in your talk, I think. Is that a fair comment?
Yeah, something similar. Yeah.
Okay. Avinash, thank you. I recognise time is moving on, so perhaps we can move on to Nicki and perhaps circle back onto some of your talks, but thank you ever so much for a really interesting talk, and I hope that everybody listening has been has had taken something away from that. But I think what we'll do now is perhaps move over to paediatrics, and Nicki's going to start a similar case, but from a less than 18, less than 16 perspective.
Yeah,
14, 12.
I think three-year-old.
Okay.
Just to contrast a bit more. So the child that I would like to talk about is a 3-year-old boy who presented initially to his local emergency department, with the parents reporting that he'd been vomiting for around 24 hours and had a rash, sort of a red rash all over his trunk. He was usually a well child, but had a past medical history of Down syndrome, but was well with that, had recurrent follow-up and was doing well. His admission observations had a heart rate of 140 and respiratory rate of 40, which are both elevated for his age, and a temperature of 38.4. The triage nurse performed a Pews score and also documented query sepsis as a concern. We're seen by medics who felt that it was most likely a viral illness, since after all that's more common in children. And after paracetamol, his heart rate came down somewhat and respiratory rate came down, so was discharged home. Unfortunately, 24 hours later, this little lad came back and went to ED resus. He'd continued to become more unwell, developed diarrhea, was irritable and very drowsy, and the heart rate was even more elevated, and his first blood pressure was very low, and sepsis 6 was initiated by the team. By the time that the PICU team came, he was already starting to develop purpura, so a non-branching rash to the extremities. His hands and feet were very cold, and with the history of diarrhea, the team were concerned that it might be toxic shock syndrome, as well as sepsis, so received antibiotics for both the sepsis protocol and toxic shock. And indeed, the blood cultures later grew strep pyogenes.
Nicki, I'm terribly sorry to interrupt. Could we go back 2 slides? And just to put the heart rate into an adult context for all of us adults only physicians, what would you expect the upper range of a normal heart rate to be for a 3-year-old?
For a 3-year-old, I mean, anything above, say, 110 would be a bit unusual. 120 to 130 is moderately raised, and say 140 is, you know, significantly raised.
Okay.
And then RESPs should be 25 or less. So,
yeah,
you know, they're quite abnormal values.
Sorry to interrupt. Thank you.
I think the confusing thing is often when a child is febrile, those parameters do go up, regardless of the cause of the temperature.
Including the respiratory rate?
Yeah, they pant. Yeah, so it can be quite tricky.
Right. Just sorry, out of interest, do they pant because their acid base is disrupted, or because of the critical illness, or because of the illness?
They pant because, well, I think it can be a mixture, but I suppose with the fever, to try and help reduce the temperature, they pant. But I suppose the acidosis can contribute to that as well.
Okay, thank you.
That's okay. So I just wanted to bring the contrast with adults is that children are not just small adults, but there are a few differences when it comes to sepsis. So there are, like with adults, a variety of discrete subtypes of sepsis, but some are quite unique to paediatrics. For example, you can have congenitally acquired infection, so be born and pick up an infection from your mum, and then present with sepsis. And that's, you know, very different organisms compared with community acquired. Infants can also present with viral sepsis, so can develop multi-organ failure from a virus that might otherwise cause an older child or adult very mild symptoms or moderate symptoms, for example, influenza or adenovirus. And then there's also a growing group of children with medical complexity. So this is children that may have complex medical needs, disability, and they may have recurrent hospital admissions and have maybe flora that are resistant to particular antibiotics, and also have infections that are a bit unusual, maybe related to medical devices such as indwelling ports, PEGs, tracheostomies. And then their presentation can be very variable. So I know that from my small amount of exposure to adult medicine that often with bacterial sepsis, that adults can be in warm shock, so vasodilated, tachycardic, hot, whereas with children, actually a cold shock, so being shut down, having cold hands and feet, mottled appearance is actually more common in particular the younger group of children. And it can also present quite strangely, so you can just have apneas, so pauses in breathing with the younger infants. And hypoxia can be the only presentation for some babies because they get a pulmonary hypertension related to the sepsis, and that can be the only sign. So, you know, that can be quite tricky. And I think the other thing is children, the younger ones, can't report their symptoms. So we're reliant on parental reporting, and their concerns should be taken seriously. And I think also several other conditions, as we've touched on before, can closely mimic sepsis. And in children, the unique things are sort of congenital cardiac disease, so a duct-dependent lesion, for example, an inborn error of metabolism, which is why we'd always advocate in a child that you think might have sepsis to check a glucose and a lactate, and in an infant, check an ammonia level, because that can really look like sepsis. Non-accidental injury or accidental ingestion of medicines that are lying around the house can also cause a septic, sort of collapsed child. And then more recently, we've got this spectrum of PIMS-TS, which I don't know if anybody has come across that, but it's a pediatric multi-system inflammatory syndrome, temporally related to COVID. And these are children that have been exposed, had a history of COVID a number of weeks prior, and then present with a shocked state. And obviously the treatment for those children is quite different compared with septic shock. But ultimately our approach is that we would give antibiotics first, follow the sepsis 6, and then look for clues and try and narrow down the exact diagnosis after that.
Well, before we move on, there's quite a lot to have there. So I notice in the Q&A, and please feel free, everybody who's on the call, just to drop something in the chat or the Q&A. But somebody then wrote, it seemed like a small heart rate drop from paracetamol. I wouldn't want sent home, but I do work with adults. What do you think about this kind of dynamic sort of response to treatment? How much does that play a part in your assessment of the critically ill child?
Yeah, it's tricky, and I think that the person that's commented on that is correct. That is a small change. I think there's a lot of factors at play. I think the 4-hour wait in ED and the pressures that the NHS are under at the moment often means that there's often a perceived very short window to observe children like this. And if they look like they're starting to improve and maybe eating a bit of something, often there's pressure to maybe send home from the acute setting. Whereas maybe if we had a little bit more luxury of time, might observe those children for a little bit longer and then notice really they don't perk up as much as you'd like.
But broadening it out generally to inpatients as well.
Yeah.
I mean, is that a factor, or do you take everything purely on, as you see them? No,
I think response to treatment is an important factor, particularly, response to antibiotics, response to fluid resuscitation, for example. And I think, in whichever setting, I think safety netting is really key. So if you feel that somebody may have responded to a treatment and they go home or they are left on the ward, I think safety netting, whoever is caring for them, to know what to look out for, and just to make sure that they are going to continue to improve is key.
So if I could just bring Melissa in there, in your role, how much concern, I suppose, is there that if you screen and somebody triggers, that then you instigate a treatment, but actually they just need that little bit extra, and whether that happens on the ward or whether that happens elsewhere in the hospital, that's able to be delivered. I mean, how do you balance that in your role?
I think it's really, as Nicki said, it's that reassessment of what initial treatment you've put in. And the one thing, my background predominantly is adults, but I cover the Great North Children's Hospital, obviously at Newcastle. And we do find we get a lot of kids with temperatures that after a couple of hours, bit of paracetamol, they're up drinking, they're back to normal, really. So it's like we say, it's getting that safety netting in place, making sure that we tell the parents what to look out for as well. So it's about having that written information of what to look out for, but also what we would expect if they were going to deteriorate, but also keeping them safe. And I think my biggest thing, and it's in adults and pediatrics, is getting that senior review. So if you do suspect that it could have been sepsis and they've triggered on the sepsis pathway, then it might be just getting that senior clinician review to say, what do you think, where should we go? And it just gives that more holistic approach, I suppose, as I've said before, getting another person's opinion to go, do they need to be admitted for further treatment? Do we need to monitor a little bit more closely, or is it safe for them to go home with the safety net and to come back if there's any concerns?
Yeah, and if I could bring Avinash back in, I mean, how much of support of outreach and the like is supported by senior people? And I don't know if you see children in your hospital?
No, Tori, unfortunately, it's mainly the adults we see are intensive care.
Yeah.
And I think you're right in saying outreach is very helpful. And we've got a good synchronous work that we do with the outreach team. So a lot of times, if there's something that's still in the gray zone and they're not thinking it's going to be escalated pretty soon, they keep reviewing the patients. And in the event that anything changes, they let one of the registrars know, and they always review the patient on time. There's no delay of any such kind in such cases. And I think if there's anything that needs to be picked up early, it happens. And if the patients need to come in, they do come in ICU on time.
Thank you. And so I just saw a question about the PAR score, which I assume is the prognosis after resuscitation score. Intraobservable variability for resuscitation success is problematic. Also important not to conflate not for intubation means not for ITU. I don't know if you can all see that on the questions. Certainly, from my point of view, I think we tend to not formalize the PAR score. So we don't use the PAR score in our hospital, or at least certainly not in the critical care. But what we do try to do is sort of put in a generalized plan in terms of an escalation plan. And yes, certainly one of the things that has been really difficult to get across has been this idea that just because somebody's not for intubation doesn't mean that they're not for escalation to ITU, because certainly what we've tried to impart to our hospital is this idea that intensive care is not just about organ support, it's about a package of care, and that includes, you know, increased numbers of nursing staff, increased numbers of medical staff, the training that all nursing, medical and AHP staff get, ACCP, extra numbers and all those sorts of things. And so certainly focusing in purely on organ support, I think, isn't necessarily the sort of thing we would try to encourage. So I don't know if we're getting off the subject a little bit, but Avinash, just please if I could bring you in for that bit just before we get back to Nicki, please.
Yes, Tony, I think the parts code, it did come in, but it's not very popular again. And our decisions is not just based upon a few variables. It's more of, again, frailty comes in, and it's a very debatable topic when we speak about frailty. The GMC guidance says we have to make sure life is prolonged to whatever extent we can, but balancing it is very difficult. There's been a number of studies in literature on frailty scoring and other ways of admission criteria. But to put it down to an individual, it's very difficult. So I think it's more of a process where we have to look at things individually on a case-by-case basis. And of course, whenever we are in doubt, we speak to other team members or colleagues. And I think if we come to more like a shared decision-making plan, including the patient or their families, that probably is something more optimal rather than sticking to a few scores.
Yeah, I think that's right. I mean, I think the only thing is that the GMC only asks us to provide appropriate therapies. And so it's perfectly possible then to assess somebody and say, well, actually, in these circumstances, it's not appropriate to intubate. So I think it would be a very slippery slope if as a country, we moved to delivering everything to everybody all the time, because, for instance, ECMO can't cope with that demand, because that would be the logical end point of that. And so I think this is getting away from the point of our webinar. So perhaps we should pass back to Nicki, please.
Thanks, Tony. Just a very quick point to mention when we talked about parents knowing their child best and specific groups of children that might be affected more by sepsis. One example in this case is a child with Down syndrome, where sepsis can present atypically. They have a weak immune system. And I think this is just one example of many different conditions where we just have to be more cautious when it comes to diagnosing and treating sepsis. I'll only briefly talk about what we do in terms of treatment, but essentially it'd be much the same as adult care. We need to stabilise our airway, breathing, circulation. We need early broad spectrum antibiotics, and to identify the source and look for some of the other conditions that I mentioned. And then it's all our organ support is aimed at reducing oxygen consumption and increasing oxygen delivery, which is probably a topic for a whole other webinar. But essentially, one of the ways that we can reduce oxygen consumption and improve delivery is by intubation. And I just wanted to touch on that very briefly, if that's okay. Because I know particularly when children present to hospitals that are predominantly adult care, and doctors and nurses that predominantly treat adults are called to resus this awfully sick child, it can be very stressful. And I think just a few little pointers just to help. So I think it's key that we think about intubation early in children, because for a number of reasons, but particularly respiratory effort accounts for a larger proportion of oxygen consumption in children than it does in adults. And in the shock state, it'll be contributing to their deterioration. So we talk about early intubation. So after around 20 to 40 mils per kilo of fluid resuscitation, we should be thinking about it and planning, because it takes a bit of time. And we usually do a modified RSI. And by that, I mean, we do deliver some breaths, because hypoxia is a bigger issue, particularly in infants. And we also titrate drugs in smaller doses, so they do not need an induction dose. of anaesthesia, often in septic children, a quarter of the standard dose. So my general practice is to use ketamine and rocuronium because they're fairly cardiostable, and doing a general anaesthetic for a procedure, I might give 1 to 2 milligram per kilo of ketamine, whereas in a septic child I could give a quarter per kilo, and that would be enough. And also I think safety first. So as in adult practice, I know you love your checklists, so we'd use a checklist and make sure that the most experienced person with paediatric airways does the airway. It's not time for anyone to practice. And I think making sure you have someone experienced as team leader is key. And planning for the worst. So a rapid desaturation is very common in little ones, as is hypotension. So having resus drugs drawn up. I often have a peripheral adrenaline infusion just on in the background, just trickling in, and fluid ready to give, and planning if the child does have an arrest, who's going to do what, who's going to do compressions, what are our reversible causes we need to address. And with that, having good access to having an IO at least ready to go in, if not in already while you're intubating, so that you can give those inotropes that you need. And calling for help, get PICU on the phone. You know, even if we're not in your hospital, there's transport teams all around the country that are very willing to support over the phone to have the safest possible intubation and retrieval as possible.
Thank you, Nikki. And just before we do that, there's been another question in the Q&A, and it just says, because there are things that mimic sepsis in pediatrics, do you use things like calcitonin, procalcitonin, to differentiate and decide on antibiotics? And what is the place of sepsis markers in your practice?
It's tricky. I think we certainly wouldn't pin a diagnosis of sepsis purely on, say, a CRP. And like anything, it's just putting together a bunch of clues and making sure that you've absolutely ruled out some of the other key things. Sepsis is common in children, so we'd always give the antibiotics first and look for other things later. I wouldn't do a procalcitonin or a CRP and then give the antibiotics. It's better to do it the other way around. And we use things such as POCUS to try and identify sources of infection. For example, a common one in infants is meningitis or collections in the head, and we can use ultrasound to identify that. But yeah, we don't use procalcitonin, and there's a lot of doubt about CRP. It's useful for tracking improvement, for example, but we wouldn't place your bets on that alone.
Yeah, I mean, I've always been taught that actually procalcitonin is completely unreliable in the neonate, but I don't know when it becomes, if at all, more reliable. And certainly it sounds as if in your 3-year-old you wouldn't use it clinically. Yeah. Lovely. So Melissa, just from leading up from that, I mean, do you have procalcitonin or CRP? Do you think it's used on the wards?
Yeah, no, same as Nikki, not in pediatrics. We wouldn't use it, might use it as a marker of general deterioration, but within adults we did use it quite a lot initially with COVID to really get that differential. I know when I went back to ITU, we had a lot of really sick COVID patients that were just getting a little bit worse, and we were thinking, is it COVID? But actually when we did a PRT, actually that was coming back at 8, 9, so they actually had bacterial sepsis as well. So we were using it, but actually I think we needed a bit more evidence around it, and as a trust we haven't adopted that fully yet. So we do use it, but not to change the system. We would give the antibiotics the same in pediatrics to adults. We would give that really quickly and then potentially do that as a sort of test later along. Like Avish said as well, with the we wouldn't wait for cultures, we wouldn't wait for bloods to come back. If we suspected sepsis, we'll give the broad spectrums, and then we'll use the start smart and focus, the national thing of going, well, do we need to escalate? Do we need to change? Do we need to actually just stop? This isn't sepsis. It was just a simple infection that needed a couple of doses of antibiotics.
Yeah, and certainly our colleague Paul Dark, who's up in Manchester, would be pleased for me to plug the Adapsis trial, which is actually looking at the place of markers such as procalcitonin and CRP. So hopefully we'll have more information about that as that trial begins to continue recruiting. And hopefully it's in a hospital near you right now.
Yeah, it's in ours, I think. It's in Newcastle.
Yeah, exactly. And and I think that certainly that's right. Certainly what we found with COVID was that with the finding that tocilizumab was able to improve outcomes in COVID, we suddenly had a huge crisis of confidence about whether some of the sepsis-like syndromes that you were seeing in COVID was actually being driven by superadded bacterial infection. And so we've found that we've had a huge increase in our antibiotic use, and we've tried to rein that back in with the use of procalcitonin, but I don't know how successful we're really being. And I suppose I'm saying that we're probably not being very successful really, because there is so much diagnostic uncertainty, certainly around COVID. But yeah, so yeah, Avinash, what happens in Preston about the use of procalcitonin and other markers that you might use?
So we've got a protocol. I think after discussion with the microbiology team, we came up with a protocol of having a value greater than 0.25. Even somebody with COVID, we would start them on antibiotics. But this was, again, I'm not sure this is very evidence-based, but we just want to be very sure that we're treating all the secondary infections that can happen with any viral infection. Now, coming to any evidence, I would say pro rata trial was one of them, which said we can de-escalate antibiotics if the PCT levels come down to less than 80% of the initial, or maybe less than 0.5. There's some weak evidence in community-acquired pneumonias if they were bacterial or viral, and PCT would help us detect that. But I think anywhere else, including pancreatitis or any other infections, there's not much studies which have come up for procalcitonin yet. And along with that also, I think it will take at least 24 hours for the procalcitonin to peak. So sometimes if somebody has come with lesions of infection, if the procalcitonin isn't raised, that doesn't mean we can't give antibiotics. Maybe it's just taking its time to peak by tomorrow, maybe day after, which is similar to CRP as well. So again, it comes down to, I think, clinical decision making, and time is very critical in these cases. Yes, these markers do help. And I think there are many more markers which are still under investigation. There's something called as circular DNA or circular mRNA, if I'm not wrong. But again, it boils down to the clinical situation at the end. And I think COVID especially, that there was mentioned that the procalcitonin can itself inherently go up just because of COVID infection itself, irrespective of somebody having a bacterial infection on top of it or not. So it's, again, a very dubious plot that we get into when we think about procalcitonin as the sole hero, the sole winner. Unfortunately, that's how things are.
Absolutely. I realize time is going on, but we did start 5 minutes late. So obviously people will drift off as and when, but Nicki, we've got 5 more minutes to go. I did have one more question about antibiotics where it may differ from adults, whereby do you tend to use personalized antibiotics if you know the patient, but then otherwise you just use generic recommendations, or how does the antibiotics work? Yeah,
so we do have a guideline for broad spectrum antibiotics, usually something along the lines of cefataxime, with or without gentamicin, depending on the child's age. But for children that are known to us, in particular known to critical care on a frequent basis, we do have to adjust that because they do have multi-resistant organisms. We are lucky to be supported by an excellent medical microbiology team who want to be called about these patients around the clock to make sure that we are getting it right, that we're not overdoing the meropenem, for example, which I think we have a tendency to. Yeah, so we do work closely with them. But it's a moving target often with some of these.
Okay. And does the antibiotic change with age? Do the antibiotic, the generic antibiotic regimen? So, say that you get over 12-year-old with suspected sepsis, would the antibiotic, the unguided antibiotic recommendations differ compared with the under 12-year-old?
Not at that point. I think the general cutoff is under 1 month, 2 months, 3 months. Most pediatric guidelines have a different set of antibiotics from a congenital infection point of view that I mentioned. Otherwise, no, it's similar in older children. Great.
Well, I recognise that time is perhaps going on. There's no more questions in the Q&A or chat. So I think we should begin to draw to a close. I'd like to thank Nicki, Avinash and Melissa for their inputs, their talk, and a really enjoyable Q&A session. And I'd also like to thank the Intensive Care Society for putting this all together, and keep an eye on our webinar series. But for this afternoon, I'll draw it to a close. Thank you to everybody, and goodbye.
Thank you, everyone. Bye.